Hello, everyone. It's always weird when I am by myself because I'm expecting Liz's face to pop up next to mine. And she's the better looking of the two for sure. So I'm always expecting her. Liz will be here any second. As you may know, Liz actually runs the OCDI in Houston, Texas. And because she is the director there, she's running a whole treatment program. And so because of that, a lot of times she's not dealing, that makes it sound bad. She is working with clients and probably is doing that, but she'll be on any second. And then my hair's crazy. I don't know what's going on here. I try to fix it. It's not listening to me. So we're just going to pretend it looks normal. But I hope everyone's doing well. I hope everyone's doing good. I don't know if you saw the state of the IOCDF, kind of like the state of address yesterday with Becky, our new executive director. We also had Matt, who's been a valued staff member, and we have Amanda, who's in charge of communications. Matt is not just a staff member, by the way. He has been kind of running the entire foundation for the last almost year. He's head of staff. He does incredible things. He knows communications. He has OCD himself. Is an amazing three of them to see yesterday. Just talk to you a little bit about what the IOCDF is doing. And as many of you know, my connection with the IOCDF is from when I was at my worst. I think with a lot of other people out there, you can probably relate to my story. I had no clue I had OCD, despite years and years of giving in. Just like everybody else, had that kind of like misunderstanding of OCD. And since a lot of my thoughts were around harm thoughts or a lot about my health or a lot of magical thinking, I just didn't think it was OCD. And so after being hospitalized and being at my lowest moment, we did try to find treatment. And I wonder if anybody in the chat can relate to this, but we searched through our insurance. I went to so many different therapists. We actually called so many different therapists. And many of them did not even call back because they didn't know what OCD was. We had a bunch of people call back, say they didn't know what OCD was. But I went to, I think, 5 or 6 therapists, and they just had no clue what I was going through. They were completely lost and confused, or they said they could help and couldn't, and were doing inadequate treatment. So it wasn't until my mom found the International OCD Foundation where she found a specialist in OCD. It was a little far, and especially if you live in Southern California, you know the traffic out here is horrid. So with traffic, it used to be about a 2-hour trip there and 2-hour back. So about a 4-hour round trip for treatment. But as many of you know, when you finally find a therapist who understands and specializes in OCD, like my mom found through the IOCDF, it was life-changing. And so I just got word Liz is joining, so she'll be here one second. But because of finding the IOCDF, I found an OCD specialist who I worked with for about 2 years. And went from me being agoraphobic, housebound, couldn't function, to end up being who I am today. So I'm so thankful for this organization. So I think the state of the IOCDF was amazing. I see a couple people. I see Joseph put in the chat that they enjoyed it. So I'm so glad that many of you watched it. I think it was an amazing stream, just to up to date with what is going on with the IOCDF. All right. Let's put up Jane's comment let's jump right into it. 12:07, Brennan. Did it get worse as time went on? I'm still struggling, but finally got referred by Dr. Whelan. So to answer your question, Jane, unfortunately, yes. My OCD got so much worse as it went on. It started when I was a little kid. It was my first kind of symptoms when I was a little kid is I really didn't like textures. So I only wore the same outfit and slip-on shoes. I remember that I could not wear shoes that weren't slip-on because I hated the feeling of the laces and I hated the feeling of that, but also textures and the tag. I could not stand it. And so I had this one outfit that I wore over and over and over until kids started making fun of me because of that. And then I remember too, I'll never forget, I was playing soccer and I climbed under the fence to get the ball and ripped my uniform shirt because I grew up lower class. We didn't have a lot of money, so we couldn't buy me another uniform shirt. So my mom sewed it, and there was kind of like a patch mark there. And because of my OCD, I used to walk around and put my hand over it because I was so embarrassed that there was something that was wrong. So I ended up wearing sweaters to cover it. We had a uniform, this bright red sweater, even in the heat, because I was so embarrassed. And finally, my mom got me a new shirt. But it started out pretty mild, Jane. But as it went reinforced and untreated, it got worse. I mean, in high school, it got to a point where my relationship OCD and contamination prevented me from almost graduating my senior year. I could barely get to school. And then when I ended up going off to college and living on my own, I think the shift from living with my parents to living with college and to, just kind of reinforcing it for so many years, I just started giving in until I was doing 16 hours of rituals a day. I had to quit my job. I had to quit school. I stopped seeing my friends. I was living on savings, wasn't seeing my family. My roommate and I weren't getting along. So we were kind of isolating each other from everyone or from each other. And I just kept reinforcing until I became housebound, agoraphobic, couldn't do anything. And it wasn't until I ended up getting an intervention. I had hit my lowest point and unfortunately had a suicide attempt, and my family stepped in, and that was when I finally started looking for treatment. But that's why I always tell people it's so important to find treatment, even if it's coming to these live streams, finding a support group. I always think it's better if you can find a support group led by a clinician, so you're getting clinical direction, going to conferences, going to events. Even if you can't get into therapy yet, I think, Amy, you put in the chat, like, hard to find somebody who takes Medicare. I know working for a treatment center, we do take some insurance, and that was a long, hard fought battle to get insurance to take OCD seriously. So I'm really excited with Becky on board. That's one of her specialties, and really figuring out how to get OCD covered and get it taken seriously so that people can get insurance to cover it, insurance reimbursement. I don't know how you all feel, but I pay so much a month for my insurance. And I got a sleep study last year and they didn't even cover a penny of it, and I had to pay out of cost. So insurance doesn't seem to like to cover things. So I totally understand your frustration, Amy. But yeah, so Jane, that's just a little bit about my story. It does get worse, unfortunately, if it's not treated. So I do think education is a huge part. So learning what's going on in your brain is so important. I think a lot of people take way too much investment into the content of their thoughts. And we were talking about it yesterday in a group I run, a support group. And one of the members was talking about how OCD was telling them that they were going to hurt the people around them. And then later on, they were with a friend and like walks the friend home to make sure they're safe. And it was like she was starting to realize as she was talking out loud, how come in one breath OCD is making me feel like I am this horrid person who's going to hurt people, but my true self was actually walking my friend home to make sure she's safe. So typically the reason you have the content of thoughts that you have is because it's the exact opposite of who you are. I always let you all know that I had harm thoughts around my grandma and youngest sister, yet those were the two people in my life I was most protective of. My grandma was older and felt very vulnerable, and my little sister was young and felt very vulnerable. So I wanted to step in and protect them at all costs, right? I mean, they weren't in any kind of danger, but I always wanted to protect them and make sure that they were okay. And so then OCD told me, well, what if you want to hurt them? What if you want to, turn around and cause them harm? And that caused me to unfortunately take way too much investment in those thoughts and did the things that most people with OCD do. Started to think about those thoughts all day, asking myself if I could hurt them, avoiding them, analyzing in my head, ruminating. All that did is just make that story louder. And it made me believe it even more. So I pulled back more, and those compulsions, man, just reinforced it. So when I learned that those thoughts were unwanted, they were the opposite of who I was, I stopped ruminating, I stopped giving into them, and I stopped taking them so seriously. I use humor in my treatment. I don't know if anybody else uses humor. It's hard to be humorous sometimes with OCD, but I started getting to a point where I was like, I'm just not going to take these thoughts seriously. I would never, ever do that. So why am I treating those thoughts as if they're possible? They're just not. And so I stopped giving into those thoughts, and I changed my behaviors and really started engaging. My therapist and I worked up a plan to start eating with my grandma, watching Wheel of Fortune and Jeopardy and Family Feud. I don't know if anybody likes Family Feud. I'm obsessed. The only problem is nobody in my family is as good as me. So I would go up there and be the only good one on the team. And then I'd be so angry with my family if we lost. So if anybody wants to adopt me that has a couple of family members good at Family Feud, please let me know and I'll join your team. But in all seriousness, I started spending time with them, and I got to a point where I recognized I didn't want to harm him. Liz, I said my better half needs to come.
I'm here.
Yay. I said they're going to have to deal with me, and the better looking one isn't here yet. So
Whatever. Good.
How are you doing? I was just talking a little bit. I jumped right into a comment. Earlier, Jane had asked like if OCD goes, she's so excited. She found Dr. Whelan at the IOCDF conference and got referred, but she was saying like, does OCD get worse over time? So I was just kind of talking about like, unfortunately, like my personal trajectory of just untreated, it got worse and worse over time.
Yeah, and that's exactly what research would tell us, that untreated OCD gets worse over time, and that it will impact every aspect of quality of life. So every facet from, friendships, relationships, work life, social life, activities of daily living. And actually, if you guys saw the International OCD Foundation, we did a post last week that highlighted this. And I know that some of you would have liked it to be worded a little different, so we're working on that. But what we're really trying to highlight is that untreated OCD has really significant adverse impacts, both on quality of life, length, etc., you name it.
Yeah, and I think that's so important to know, because I do believe when I talk to some people that say they're not ready for treatment, I'll ask them like, we'll kind of talk about it. And typically one of the things they say is like, well, I'll just kind of wait it out. It's been negative, but I'll kind of wait it out. And most of the time when I reconnect with that person, if they reach back out to me or I see them at an event, their OCD has almost always gotten worse, because unfortunately we're reinforcing it and it just turns it worse. I think that's that. I wanted to jump into another question, but before we do, Liz and I are here today. Today is an Ask the Expert. So really this show, first and third Wednesday, sometimes we bring friends with us to answer questions too. But the point of the Ask the Experts is to answer all your questions. We have a huge list of pre-submitted questions that we'll definitely get to, but we also want to answer your questions as well. So please, whatever social you're on, I see YouTube, I see Twitter, I see Twitch, I see Facebook. So we're getting everybody from everywhere. Just put in a question and we'd love to answer it. So I'll throw a question that we got at 12:10. Do we see comorbidity of OCD and sensory integration dysfunction, also known as sensory processing disorder? So do you see a lot of that? I'll kind of jump in, then you could add, Liz. I do see a lot of clients. I'll say, Spence, most of us call it sensory processing disorder, but either one is the proper term. I see it a lot in individuals with OCD, and it usually is ways. Either they have comorbid autism, so sometimes with autism people really struggle with sensory processing disorder, but also with OCD. So a lot of times people, kind of like what I was talking about earlier, is like one of the things that I see is people have like a hypersensitivity or overstimuli to certain like sensory processing. So a lot of times it might be loud noises, it might be certain textures of their clothes, they might just not like to be touched. And so with OCD, as always, we hyper focus on things. With autism, individuals with autism definitely have a reaction sometimes to loud noises and certain textures. But those of us with OCD that also have sensory processing disorder, which I showed much younger, there's just a hyperfixation on textures. Sometimes it can be clothing, etc. So I do see that in my practice a lot. And usually if it's OCD based, it's because there's a hyperfixation on the senses and people get really irritated because they feel like they can't. I don't know if you wanted to add anything.
Yeah. I think that we find that OCD is often comorbid with some type of condition, and sensory, any sort of sensory issues, whatever, like, I think that there's a strong chance. I don't know the data on those comorbidities with OCD like I do some of the others, but I think that we do often see them going hand in hand. And again, sometimes, we know that autism and ASD can often involve sensory concerns, sensory issues, all of the above, and that is very comorbid condition with OCD.
Yeah. This isn't really a question, but I think it's a good thing that we can discuss. So at 12:14, Wendy put up, OCD is such a mean disease, trying to steal all those people and times that are special to us. We were talking about this in my group yesterday. One of the things that almost always happens, I saw a comment, I forget where I saw it. Amanda Petrick Gardner had said it about our OCD, and I even see it with every single, not here, Brennan, you could put Wendy back up. I saw it on Facebook or social, and she had said something about relationship OCD, and she was talking about how like some sometimes people will ask their partner for so much reassurance that actually their worst case scenario kind of comes true, because the partner is bombarded by questions and is always getting peppered with all these different relationship-based questions that they finally just kind of step out of the relationship. But I think what it is, Wendy, is OCD lies to us and tells us if we give into those compulsions, if we shift our whole mindset to do what it's asking of us, great things will happen. But I want everybody to ask yourself, if you've been giving into OCD for a long time, has it worked? I mean, has it bettered your life? Typically, my perfectionists around school, it might work in the beginning, but over time, they're struggling to turn things in. They're procrastinating. They're getting poor grades. People with scrupulosity over time start to like pull back from the church because it's too triggering. So I always ask my clients, one of the questions I ask them in the beginning is, has the OCD worked for you? Has it given you anything? Do you have anything to show for it? So maybe you could weigh in, Liz, like for you, do you see that there's this belief in the beginning that it's somehow helping us and then it all comes crashing down?
Yeah, I mean, I think that what I want to remind us and push is that at the end of the day, what we know is that OCD is going to capitalize on us when we're most vulnerable, and we're going to feel most vulnerable during important times, right? And so if we have anxiety about having anxiety, which is really what OCD is, if you think about it, at the component of OCD, it's that we don't like anxiety. And we can all be like, well, that's not true. Like, I'm willing to have a lot of anxiety. It's like, no, we have a lot of anxiety, and that's a part of our life and part of our disorder. But the reality is that the reason we give into rituals is because we don't like the anxiety. We don't like the distress. And so we end up ritualizing to try to feel better. And so the anxiety is going to be heightened when it's a big event, when it's a life change, when it's something we're excited about, a trip that we want to go perfect, the wedding, whatever. And that's OCD's like prime time, right? To be like, oh, well, let me try to ruin that. Let me try to hurry up and jump in there. I don't know. But like what I'm trying to say is that at the end of the day, you know, that OCD wants you to try to make certain events, like it wants to capitalize on those. It wants to control those certain events. And actually what we know is that you're going to have more fun. You're going to be more present. You're going to enjoy your events so much more if you are able to resist and fight OCD early on and go ahead and screw it up and do the opposite of what OCD wants. You'll be present. But if you actually go in trying to answer to OCD so it stays great, that guarantees that you're not going to be present and you're not going to enjoy the event that much because you're going to be stuck in OCD land.
Yeah, it always makes the opposite of what you're hoping initially is going to happen. I'm going to answer the next question because I was talking a little earlier and it was about me. And then I'm going to ask you the question right after that because I think you'd be perfect to answer it. So Brennan, at 12:15, Chris, did you get on medication? And would you please tell us the percentage of benefit compared to therapy? Yes, I did. I'm always honest. I didn't go on medication for the first 6 months of my treatment because I had a lot of fear around medication. Nothing about the medication itself, I would say per se, but for me, it was more of like putting something inside me that I couldn't control. I couldn't get out. What if my hands were dirty when I took the pill? Or what if there's something on the pill? I mean, just all kind of like made up stuff. What we know with research is typically people will see about a 40 to 60 is kind of on the higher side, but about a 40% reduction. But I will say almost all psychiatrists that I personally know always recommend that there is a combination of both CBT and specifically with the emphasis in ERP with medication. So I have known some people that aren't wanting to do any kind of treatment. They do just take medication and they'll see a reduction in anxiety and symptoms, but we really know the treatment is what helps. So we see there's research that shows that as high as, if you look on the IOCDF's website, I think it's by Eric Storch, but we see people as high as 70% on average find benefit from ERP. And I would argue like that's in a very clinical, like studied setting. If you talk to Liz, myself, other people that work in practice, we see even higher numbers with people that utilize ERP, CBT, ACT, et cetera, mindfulness, DBT stuff. We see a higher than that. But so I would only say that medication is great. It's a great adjunct. Please find a psychiatrist that understands OCD, meet with them, ask your questions, but make sure you're doing therapy as well. All right, Liz. So this is a good one because I think sometimes we forget that people are going through this. Lucy from YouTube asked, my parents think that OCD is being a neat freak and being perfectly organized, but no matter how many times I tell them what it really is, they won't believe me. So therefore I can't get a diagnosis. So what does somebody do if like their friends and family have a very skewed, I think even sometimes doctors have a skewed understanding of OCD that's preventing them from getting care?
Yeah, this is so hard. And I first just want to validate that, like, good for you for attending these webinars and trying to learn more and understand more about what might be going on. I think that the first thing I always say is to start with education that's given from someone other than ourselves. What I find is that family members who are a little bit more resistant or hesitant, right? Goodness, sorry, my earbud. They tend to have a harder time hearing it when it comes from us versus another clinician or professional. And so I would utilize IOCDF's resources. I would go to peaceofmind.com, go to IOCDF.org, go to YouTube channel of IOCDF and share videos, share education, share handouts, whatever way they like to process their content. Like, I would try to meet them where they are and provide that information. And then the second thing is, I wonder what it would be like to focus more on, hey, I feel like I might have OCD. I don't know what's going on, but could I go to a provider to be able to get an appropriate diagnosis? And I'm hoping that they would be willing and helpful and considerate of that. If you're able to show, here's the things that are going on in my life, and here's the disruption that's happening, and I need support and help with it. But it's hard, But I always say start with education that's from others and from professionals in the area that can help, because sometimes it's just easier for other people to hear it when it isn't coming from us.
Yeah, love Lana put in the chat, maybe Lucy, they could join one of these lives. There's definitely this live stream. We have the family one now that you could go to. I also run a free family and loved one support group every second Saturday of the month. Liz has been featured on it multiple times. So it's good for parents to sometimes come and hear. So I'll have Brennan just put in the chat. So if you just email info@ocdsocal.org, we can send you the link and potentially they could join. The next question.
I'm going to ask the next one for you, just because I think this leads exactly into what you were just saying with what you guys offer at OCD SoCal. So from Cheryl at 1117, my son is 34, has contamination fears. He has both of us jumping through hoops to accommodate. We need telehealth as no one is in our area. Is it successful through telehealth treatment? We need help.
Yeah. So Cheryl, first of all, thank you so much for being here. I always say this, coming to lives like this and things, it really does start your journey of recovery. And I do believe, Barbara Van Appen, who is at USC, who is a big a leader in the field around family accommodations, is one of my mentors and one of my idols. Just don't tell her that. No, I'm just kidding. But she has always taught me from an early point, and I truly believe this, that OCD is a family disorder. And so, meaning not that the whole family has it, but more so that if it impacts the rest of the family, there really needs to be some family intervention. And so, Cheryl, I'm so glad to see you here. So I just want to say that, first of all, Liz and I appreciate it. And we know that you're better off because you're getting these resources. I am going to have Brennan put the email in the chat, but Cheryl, please email us. Like I said, it's a free service. It's every second Saturday of the month from 11 to 1. And it's really aimed at family members, loved ones, partners, children, etc., of somebody with OCD. And we really do talk about that. How can you and your family work together to reduce accommodation so that the family is kind of moving towards OCD is not, a roommate that we want in the home? Like, how do we band together as a family and support each other while not accommodating the OCD? It is difficult because sometimes the loved one might think that you are abandoning them if you don't give into their compulsions. But that's why we talk about in this group, it has to be done collaboratively, systematically, so that the person doesn't feel that everything's being pulled from them. But you're definitely welcome to join the group. For the second half, is treatment successful through telehealth? Prior to even the pandemic, when I wrote my thesis, there was research showing that telehealth was absolutely just as effective. And then a lot of research came out during the pandemic, because so many people were doing treatment virtually, and it came out and has been found to be just as effective. What I like sometimes with telehealth even more is if I have a client that doesn't live near the office and a lot of their OCD is in the home, because I can kind of follow them around their home and we can work together. I will say the only caveat I always say is, yourself better, or in this case, your son better. Sometimes people with autism or ADHD will say it's hard to focus on a screen. Sometimes people are just not screen learners. Sometimes if it's a teen, they might be trying to like Snapchat on their computer and stuff while talking. So I think there's a couple things. Just make sure the person enjoys or finds value in learning through a virtual platform. But as for clinically, it is found to be just as helpful. I will say, like, if somebody's super severe and needs residential at a location like where Liz runs at the OCDI, I do find that more severe cases do often benefit from going to like an in-person residential versus trying to do virtual, higher level of care. So like I have had some clients that have tried to do, not with us, but have tried to do like a partial hospital for 6 to 8 hours online. And some people thrive on it and sometimes it's difficult. So it really just comes back down to the person, but it is found to be clinically just as effective.
Yeah, I mean, I think that there's a caveat to everything, right? So I don't like virtual as much as in person. I don't think it has the same benefit. I don't think I can have that same personal touch, and right, if I can do it, but I think virtual is way better than an alternative of seeing a non-OCD clinician in person, right? So I think part of it too is like what makes sense. And for some of my patients, like Chris was saying, they need virtual because we need to do stuff in their house. But I may not do every session virtual. I might do it, right? And so some of the early research when we first started looking at telehealth showed that the better outcomes for virtual therapy were if the first ERP was done together in an office. And I think a lot of that was to build rapport, to make sure you understood, right? To make sure that you were really on board. But, we know it is effective. We know it's a wonderful treatment. The caveat there is that for some folks, that's not the case, right? So certain comorbid diagnoses, being online and staring at a screen might not be useful or feasible. And then for the younger age group, so children struggle a lot more with, being online and focused and not having all these distractions than being in the therapy room, sitting together.
Agreed. 100%.
So we will jump to Steve at 11:17. Do you believe that AI, artificial intelligence, will soon be used in therapy for OCD?
It's so funny that you asked this, Steve. I was having a conversation, not about in therapy, but I was having a conversation with a client, and that's their OCD obsession right now, not for therapy, but they're afraid they're going to lose their job to AI, and it's causing a lot of like sleepless nights and stuff. And we're kind of talking about that. Hopefully it doesn't replace us, Liz, because that would be a real big bummer. We spend our whole life fighting for OCD and then we're replaced by ChatGPT. I think this is just my opinion, Steve. I think what is probably going to be more useful is VR. I do think that there are some people that are utilizing VR. I think for phobias as well, right? Like the fear of flying. I think something like that could be used. So I think VR, when it comes to the technology space, might be a little bit more on the horizon. I guess AI, like I could see you using it as an exposure, having, if somebody is afraid that they're gonna, maybe use a paragraph in a paper, they're afraid that they're gonna get caught for using ChatGPT as an exposure. But I would say, I don't know. I mean, I never really thought about it. I hope if it's used, it's going to be an adjunct and supportive and not replace. I mean, I've never talked about this out loud, but I do know sometimes some of my clients will be part of like Better Health, right? And it's where you kind of like text a therapist and they use that in place of like an OCD therapist and actually made it worse. And so they come and see me and we talk about it. So that's not really AI, but I could see something like that being used where people will talk about their feelings and have an AI respond. And that just spooks me out. I don't know how you feel, Liz.
Yeah, I mean, I think everything has a time and a place. And I think there's definitely ways we'll use AI in therapy, right? Maybe we want a patient to do an exposure that is, hey, I want you to look up I don't know, whatever it might be, Gornal Responses as an exposure. And so I just say, find us 3 articles on Gornal Response, and AI could be super useful versus my slow self trying to find them on the internet, right? So I think there's ways it may be incorporated into exposures, but I don't think it would replace therapy. Obviously I don't think AI can replace the nuances and the specificities that we need to be incorporating into OCD treatment. I do think AI could have a similar role to self-help, right? Self-help books and workbooks and those sort of things where it's a great way to get knowledge, to get information, and hopefully it'll get more defined and be more evidence-based. And I think that could be really, really useful. But, I worked in a VR lab in grad school, and I think a lot of times we thought like, will VR take over OCD treatment? Not take over, but be a big role, because you could virtually go anywhere and be triggered. And what we found is that what I always found, I shouldn't say necessarily that research found this, but it's really expensive to have a VR lab to have that work. But also I can emulate the same exposures in real life. Like I don't necessarily need to go to a virtual world. I can just do it in this world. And I think it's more useful. So, but anyway, great questions. I love this. Next question from Lucy. I heard that people with OCD, that having OCD can make you 10 times more likely to take your life. Is that true? To die by suicide? I don't know the research on that. And I know that certain disorders like BDD have a higher suicide rate than some other mental health conditions. I don't know that OCD would, and I guess I'd be curious is that somebody without a mental health condition at all? Because we know that mental health conditions can increase rates of suicide. So I don't know the data on that to say specifically yes or no, but certainly having OCD or having a mental health condition puts you at higher risk than the general population. The great news is that treatment is available for OCD and treatment is available for suicidal ideation, so that we can do everything we can to lower the number of deaths by suicide.
Yeah, I was going to say the DSM does say that people with OCD are 10 times more likely to take their life than like somebody without a mental health condition.
Oh, there you go.
But I think you explaining it like that, Liz, was important, because unfortunately some of my clients will use that statistic as almost evidence that they're going to take their life if they have self-harm. But like Liz said, it isn't about OCD specific. Well, this one is, but it's more so a mental health condition. We know an untreated mental health condition will make it more likely that somebody is going to have suicidality, right? Either thoughts or attempts. But I don't want you to hear that and then think, well, great, now I have to obsess about potentially taking my life. That's not what we're saying. That's not what the research is saying. What they're saying is people with untreated and undiagnosed OCD that aren't getting support, that aren't getting help, are more likely than somebody without a mental health condition. But it's not just OCD, it's other disorders like Liz explained. The biggest thing is getting education and community. I mean, part of the reason that we do these live streams too, we have a lot of reasons we have these live streams, but one of them is to build and foster a community. My hope is as you come to these each week, Liz and I have OCD, right? We've gone through the depths of it together, not together, but we've both gone through the depths of it and we've talked about it together, but we've also still deal with stuff and we still have to navigate life after, right? Like in recovery. And so we get it, but also you all get it. So one of the biggest things that can help prevent people from having like low experiences with mental health, such as isolation, depression, suicidality, et cetera, is community. So that's why I always think coming to this really, really helps people for sure.
Definitely. Next question, Mr. J at 1119. My 5-year-old child is diagnosed with moderate autism and sensory issues in late development. I myself am 40 and I have very complex obsessive thoughts, and now I'm diagnosed with OCD. Do you have any thoughts? Maybe it's OCD. I'm assuming they're wondering if their child also might have OCD.
Yeah, so there is about a 30% is where the research actually is all over the place. So I always land on 30 because I feel like it's the most conservative statistic, because there's some stuff that's higher, there's some stuff that's lower, but we see about a 30 co-occurring autism and OCD. Now, what we always want to make sure, I have family members that have autism, and one of the things that they do is what we call stimming, right? So like my little nephew used to roll, or a better one is when he'd go to the playground, he'd go up the stairs, down the slide, up the stairs, down the slide, over and over, and did not want to do anything else at the park. And so what we want to make sure is like what's going on behind it. If it's stemming, if it's repetitive behaviors, that's not OCD per se. Sensory issues, not OCD per se. Late development, not OCD per se. But are they having intrusive thoughts that they don't like? Are they finding themselves doing rituals to make those thoughts and their anxiety go down? So as somebody with a family member with autism and he's showing signs of OCD, we can tell the difference, right? So when we kind of have interventions with a stimming, like, hey, it's time to go, or let's try this part of the park, he's agreeable. But with his OCD stuff, he has some OCD around bugs and things like that. He will not respond well. He jumps into kind of what we all do when we feel like we're prevented from giving into our rituals. So I would say, Mr. J, for your son, it wouldn't be the worst thing in the world to find a treatment center. I know we do it. I know a lot of treatment centers will do like a free or low cost phone call or assessment. I would see and just maybe have your son assessed to see if there's any OCD. Or do you see any signs of it? Potentially that would be good. But there is some times where autism can appear as OCD. So you just want to make sure to parse that out.
Next question. Love this question from Joseph. I'm planning on attending IOCDF conference in July. This is going to be my first conference. This is so exciting. We love first conference, folks. Do you have any suggestions for a newbie? I'm feeling a little anxious about attending.
Yeah, come. I'm so excited. This is amazing that you're coming, Joseph. I always tell the story. I mean, Joseph, when I went to my first conference, I was a mess. I could barely get through it. We had planned on staying the whole weekend. I was so triggered the first day, not from anything at the conference, of course. The conference, if anything, was quite the opposite. It was enriching, but I was so triggered just from my OCD, mainly contamination. I remember that day, and we had to leave. But I saw Liz speak, and I saw her speak, and she's around my age, and just seeing somebody going through treatment, getting education, and getting better. I mean, I remember leaving, and my mom was like, "Oh, do you regret going? Do you feel like it wasn't good because you're so triggered right now?" And I was like, "No, actually, it was really great." I saw somebody my age speak, and I really feel renewed. And when I went back to treatment, I talked to my therapist about it, and it really was one of the reasons that I pushed through harder in treatment. So, just seeing Liz speak, you're going to see a lot of people with OCD talk about the recovery journey. You're going to hear a lot of different clinicians speak. What I would say, Joseph, I mean, this is more a me thing, so hopefully this is how you think. Get involved, as much stuff as you can go to. There's last year it was Dr. Grayson who did it with Alex Reynolds, but now there's like an intro event where people who are by themselves or new to the conference can hang out, meet new people. There's all kinds of support groups. There's evening activities, there's talks, there's a Saturday night social. So I would definitely say get involved in as much as you can. Totally understand the nerves. And I will say this community is super an open arms community. So you will definitely be welcomed. And lastly, if you see myself, Liz, any of the other lead and national advocates like Katie, Ethan, Val, or Tommy, we are always make ourselves available to kind of like warm up and make you feel comfortable. So please come say hi to us. Please. Do you remember your first conference, Liz?
Oh, yeah, my first conference, I left early as well. I left Saturday night because I was triggered and needed to go home, but it was just a great introduction to people with OCD, a community. I spoke, and, it just became like, I wouldn't miss a conference now. Like, it's home to me, and it's so important. So, love it. Yeah.
Yeah, come up and say hi. We were so honored.
Everyone is so sweet too. Everybody's so welcoming.
Yeah, Liz and I were so honored. A lot of you came up and said hi. A lot of you would come up and be like, "Where's Liz?" or "Where's Chris?"
They thought we were like married and should always be together, and I get it. Y'all see us together all the time. We'd love to be together the whole conference. So, Lucy, yes, ADHD and misophonia are common comorbidities with the OCD. That is true. Mr. J, I would say that just because, so the one thing I will say is that if the psychologist is saying she doesn't see OCD, you could do further evaluation. You could ask her to do a children's Y box, the CY box, which is a great quick measurement tool. But it is important to remember that sometimes autistic behaviors can look like OCD, but it may not be OCD. So we obviously don't want to overlabel. If you're feeling really unsure, you could consider seeing an OCD specialist to do that assessment or that evaluation, just so that they could look for themselves and talk it through. So many of you with great comments and feedback and tough comments about, tough responses and difficulties going through with OCD, and we get that. Next question is at 11:23 from Wright. How do you go about treating groinal responses due to sexual intrusive thoughts? I feel like I can learn how to handle the thoughts, but the groinal responses are next to impossible to not notice.
What I'm going to do, right, is actually find an article when Liz weighs in from Kim Quinlan. Kim Quinlan actually wrote a really good article, which we don't want to use as reassurance consistently, but I do think it's eye-opening for people that experience this. I also know Chrissy Hodges, who is actually going to be doing a live stream with Liz soon, does a lot of really good stuff on her YouTube channel. The problem with OCD is it can make us feel like certain feelings, we call it emotional reasoning, is valid. So if I'm at the mall and I feel like I might be pushing someone or hurting someone or hitting someone over the head, I feel very anxious, therefore I might leave the mall. And that's what we're doing with groinal responses, is when we have sexual intrusive thoughts, if we have a groinal response, and sometimes it's not just groinal, sometimes people say, why are my nipples getting hard, my heart beating when I'm walking by a family member or kids or an animal, right? What happens is people misread that as this must mean something larger. They never keep it to what it really is. And so as you'll see in the article, like I said, that will link from Kim Quinlan, it shows that people with or without OCD, many of us have groinal responses that are not connected with attraction. And I think that's an important caveat to make, is like having a groinal response does not always equal attraction. And that's what this article talks about. And Kim uses a lot of research-based stuff. And so what we have to get used to, so treating it, right? What I would do is, if I was working with a client and let's say they really, really struggle going out in public because they might have groinal responses when they're out and they're starting to prevent themselves from going out, what I'd want us to work on is getting back into the values-based locations that they enjoy and learning to respond to those groinal responses different. We're not going to try to get rid of the groinal responses. If anything, it puts more focus on it and it makes it worse, but it's practicing going to Target, walking around, shopping and leaving, and factoring in that you may have groinal responses, but not trying to make that mean something larger. We all do that with OCD. We see it in other subtypes. Somebody has a cough in their throat, they think it's throat cancer, right? If somebody has a bad thought, suddenly they're morally corrupt. So we don't want to let OCD take something small and jump it to the worst case. And that's typically what we fall for.
Yeah, there's wonderful articles on this, and there's wonderful kind of lots of people. There's Made of Millions on their website has about groinal responses. I know I just pulled this up recently. Like you said, Kim Quinlan and others. So I think that it's really important to understand the reality that like groinal responses are just like natural human responses that don't define attraction, and for us to go back to the same really good, important OCD saying we remember, which is that feelings are not facts. But then it's important at some point to do active ERP around it. So I don't want you to also like constantly reassure yourself, this is normal, because then you're still fixating on it, right? The ERP is about being able to like have a groinal response and choose to not figure it out, move on, even though it's there.
Yeah.
Love y'all's comments. Y'all are so sweet. I love Erica. You said that it's taken years, but you've shared things about OCD from IOCDF on socials and for loved ones to see. Nikki said she's really missed us. Oh no, you've been in the hospital. I'm so sorry, Nikki.
No.
You're feeling better. Sounds like you broke your ankle. That's the worst. Mindy at 1128 Chris said, my daughter and I both have OCD. Should we still attend the family group?
Yeah, Mindy, come on by. I was going to say predominantly the people that join are a family member of somebody with OCD, but so your role obviously as a mom will be great. But what we've also heard is a lot of people can't find like a support group in their area, or the support groups in their area might cost. And so people with OCD have been attending our group too and find it really helpful, because even though we do talk about how to support a loved one with OCD, there's also a lot of great guests. I mean, recently Liz, two other board members alongside Liz came on, Denise and Diane. No, it wasn't Diane. It was Denise and who was on with the support group with you, Denise, myself. Oh, Joanne. That's right. Diane, you were there in spirit. But, they were giving so much suggestions that could help people with OCD too. So I think it would be great. We're actually really excited to have Stuart Ralph as the guest. He's going to talk a little bit about his OCD. His wife is really supportive. So I'm going to hope she pops in for a little bit, or at least he's going to talk about his wife supporting. And then he's going to talk about what he's learned interviewing therapists and parents and supporters of people with OCD over the years. But we feature families. Liz has been on both as a clinician to answer questions, but also with her family. So it's a great group for people to attend. And Liz is going to be back on. I'm going to try to see if she wants to be on in April, because we'll be at ADAA the weekend of it. But if she can't, she'll be back on in November, because we're having a board meeting. And I said we can only have it that weekend if y'all jump on family group again. So
fair. I love it. No, I'd love to be there. It's so much fun. It's such a great group. And I think it's so important to attend these groups and hear from amazing clinicians, but also to be able to connect with other family members. I know for my mom, that was such a big piece for her, of like meeting another mom with a child who had OCD and feeling that connection, just like it's important for those of us with OCD to meet other individuals with OCD.
Well said.
Okay, Kate, or we'll go to Bergen. Sorry, Mr. J at 1129. Is Bergen treatment that effective that could even be 12 weeks and shows a big change? I'm waiting my turn at the public sector as they put me on the list. So Bergen is actually 4 days. It's not 12 weeks. It's a 4-day program. It's 4 days of intensive one-to-one with a clinician. So I want you to kind of imagine if you did 4 days one-to-one with Chris, 8 hours a day, 4 days in a row, or more than that, and he's doing in your home, in your house, like I think it would be effective, right? I think Bergen has shown lots of efficacy. Again, it's intensive, condensed one-to-one treatment with a clinician, which can be really great. I don't know about the long-term outcomes for the US-based studies and others. I haven't seen as much published on it, but we know that outcomes for Bergen can be really successful. The first pilot, the only pilot that's been done so far in the US, was done here at our clinic, and there were really great outcomes in a short amount of time. Not everybody is the best fit for Bergen, so you want to understand that. And of course, I don't know when the next time it will be taking the lead or taking off, whatever you want to say, here in the US. But yeah, I think it can be a really useful protocol for sure. You know, it's really great clinicians that do really good OCD work in really condensed time frame. Kate at 11:30, how do you handle when the thoughts feel like desires? Even if it's a desire, it doesn't mean anything about us, right? These are sexual orientation OCD struggles.
Yeah, one thing that I see different between people without OCD and with OCD is somebody who doesn't have OCD wakes up every day and kind of thinks things are going to go well. You know, they just have no reason not to think things are going to go well, and they kind of walk about the day kind of neutral. And it isn't until they get external information to them that they think something might be wrong, right? They get a phone call from their kid's school, or they're driving, there's a big accident. What we do with OCD is we wake up and we think something's wrong, and we have to scan and figure it out. And that is what gets us that overthinking. So Kate, in your situation, I don't know your whole background, but I'll just use like a generic example, right? So if a client comes into my office and says, look, I think I might be gay and I'm really struggling with that. When we go through the assessment, they've never had a same-sex relationship or even an attraction. They're in a relationship with somebody of the opposite sex. In fact, they're going to propose, they want to have kids, but they are misreading thoughts, desires, etc., as evidence that they must be something. And so what we think, because this is what we do in real life, is the more I think about it, the more research I do, the more information I try to figure it out, the clearer I'll get. With OCD, it's a complete opposite. The more time you spend trying to make sense of the thoughts, figure out the thoughts, focus on the thoughts, talk about the thoughts, engage in the thoughts, avoid the thoughts, the louder they become and the more real they feel. So what I tell clients to do is like, let's practice together, right? So let's say a client, this is typical for a lot of clients, going to the gym can be a trigger and they stop going to the gym. We'll have an exposure of going to the gym together because that's where they see people of the same sex in like workout clothes, people are in shape, etc. And it's practicing experiencing those thoughts and those desires without adding on to it, right? Those thoughts and those desires or whatever it feels like may come up. And that's not what we're trying to stop. But what we're trying to stop is trying to not get us to make a bigger deal of it. And that's what we all do. Oh, I just saw that guy walk by and I think I had a desire. That must mean I'm gay. And that's what people are doing. So we're going to try to do the opposite. Show up, just like we were talking about the Gornal response, be at the gym. And when you do have that feeling of desire, being like, okay, I recognize that I'm having feelings. I recognize that I'm having desires. It is what it is. Let me go back to working out. So it's not adding to it. I think that's what people forget, is the trying to figure out and make sense. Those mental compulsions just make it feel more real.
That's right. And again, Chris answered it. Trying to solve it, trying to figure it out keeps you more stuck. Aduska, you asked about what ERP is and how to do it. I would recommend, we've done an ERP 101, we've done an ERP 102 through IOCDF. You can find those on our YouTube channel. I would recommend spending some time watching those because ERP is a complex treatment that's done with an OCD specialist with your child. We don't want you to watch a webinar and then go home and try to do it yourself. But it is something that's really important to watch.
Yeah. And it stands for exposure and response prevention. So the basic idea is putting yourself back into values-based situations and learning that the fears that you have aren't going to come to fruition by pushing through. It's kind of simplified.
100%. Love all of y'all's comments, talking about so many great things, talking about treatment and different stuff from there.
I don't know if you see Joanne at 1232 says, how do you not let OCD ruin your mood? So how do you get to a point, Liz, where you haven't let OCD kind of dictate the way you feel that day?
Yeah, it's so hard. You know, I think that when we're feeling triggered and when we're feeling anxious, it's really hard for our mood to not be ruined, you know? And so one thing I've learned from Dr. Bruce Perry, who's an amazing trauma specialist and clinician, is that it only takes a couple of minutes to regulate. And sometimes that's a quick 2-minute walk, but it's something to go and regulate yourself. And so I have found that like when I'm feeling overwhelmed and anxious, I need to stop and regulate versus trying to push through it. I kind of use this analogy. I have a 1 and 2 year old, right? So this is like my life 24/7, is that, just reflecting back on this morning, it was a stressful morning. Our nanny couldn't come. And so we didn't have both car seats. And so we were trying to like go in the attic and find the extra car seat to get them to school. So we're running late, and we have work meetings that we're running late for. And it's just a lot going on. And it all compiles, right? Like when my daughter Olivia was whiny and was not wanting to sit down and eat her food and was crying because I wouldn't give her a snack for breakfast, right? It was so much harder for me to have a calm voice and explain to her why we don't eat snacks for breakfast and that we need to sit and eat the eggs that were made, and like that's what we're getting, versus me saying like, why are you whining? Like I don't have the energy this morning for whininess, right? And that's the reality of what came out. But I know I should have taken a couple seconds for myself, right? I should have gotten the car seat installed, taken a breather, maybe drinking some water, and got myself in a state where I was able to then re-engage with her versus already feeling frustrated and overwhelmed and go, and I don't slow down, And so I say that just because I want you to give yourself grace that, like, of course OCD ruins our mood. Like, who wouldn't have your mood ruined or be anxious, upset, depressed, etc. when you're dealing with throes of OCD? And we can always shift that. Right? So we can engage in behavior change that can shift our mood, that can shift our perspective, or take a minute to regulate ourselves. And so we have to learn how to do that. And it takes practice, but we do have to focus on that. Because at the end of the day, if you have OCD, there's a chance you'll be triggered, but you still have to perform at work. Or you'll be triggered, but you still have to be active in the classroom, right? And you want to be able to have those skills.
Yeah, absolutely. And I think what I always call it is like have a toolkit, right? Like be able to know when OCD is coming on, how does your mood start to shift? How do your thoughts start to look? How do you start to feel? And I think a lot of times it feels not good, but like comfortable to just kind of stay in that. But like Liz was talking, I know for me, exercise was key. If I was just like in it because of OCD, and typically I did the right thing, but I still felt the kind of negative side effects afterwards. It was really helpful for me to get into the gym. So finding your thing for sure. And remember, you're human. I mean, the likelihood to have intensive OCD experiences and not be impacted by it, that's just probably not going to happen. So give yourself some grace.
Exactly. Amy at 11:39. As a therapist I know is treating a client with EMDR because she says it's evidence-based treatment for OCD. I'd given her colleague info on OCD who also wanted to use EMDR for OCD. So can you talk a little bit about that, Chris?
Yeah, so we were talking a little bit about EMDR in a previous stream, which is one of the treatments that people find really useful for PTSD. So there's cognitive processing treatment. There's also prolonged exposure, and EMDR people find helpful. The problem is, like most people that want to treat OCD, is they'll try to use their modality that they're comfortable with to treat a disorder that has no evidence base behind it. So we don't see research backing. I mean, I think one of the things that helped me on the flip side that maybe I wish I would have known in treatment, so I'll share it with you. There is a lot of research that shows that ERP is effective for OCD. It's not one study, it's not two study. I mean, ERP was developed in 1966. If you think about it, I'm going to have to do math, but that's like 60 years. Please tell me that my math was somewhat right, but that's like 60 years, right? Coming up on 60 years that ERP has been used effectively for OCD. Now we know adjunct treatments can be really, really supportive. Some people need more cognitive focus. Some people need more emotional focus, DBT, et cetera. But at the end of the day, ERP has so much research behind it, both for children and both for adults. And so for me as a clinician, when I take it very important when I have a client in front of me that I'm going to do everything that I can in the evidence-based space to make sure that this client is going to get the absolute best care and get better. Liz does this as well. All of us as OCD therapists. There isn't research showing that EMDR is this extremely effective treatment for OCD. And in fact, sometimes when people undergo ineffective treatments for OCD, it can actually make it worse. And so I've had clients come to me that have done EMDR. I had a conversation with Kim Quinlan once. There's a lot of EMDR around her trying to treat OCD, and we don't see clients getting better from it. Liz and I didn't invent ERP. We don't have it tattooed on our face. If at the end of the day, things come out and are shown to be as effective and really helpful adjuncts, we are not going to reject it. We have learned so many other tools ourselves because we know that there's other things that can help. If EMDR was shown to be extremely effective for OCD, Liz and I would be the first people going to a training. It just isn't. So unfortunately, Amy, you're doing everything right and you're doing everything you can to educate. And I'm so sad when people have gone through hundreds, if not thousands of dollars and years to not get effective. So I really hope if a clinician who does EMDR is watching this, it is not evidence-based for ERP. Please do not try to navigate treatment using EMDR.
Exactly. And I want to just kind of throw out there, because we only have a couple minutes left, so it's a perfect time to talk about it. But there is really only one frontline evidence-based treatment for OCD. And to date, that's exposure response prevention. So ERP is the most evidence-based treatment for OCD. There are not any others that meet up, that whatever I want to say, but that are on par with the research right now that would indicate that ERP should be first, or that are above it, right? There are some other treatments that may show some efficacy and warrant further research for us to better understand where they might fall. But to date, the IOCDF and those of us as OCD clinicians on these live streams, like, we are all completely in agreement and on board and unified that to date, ERP is the most evidence-based behavioral intervention for OCD. And so that's really where you want to start and learn more about it. It is 11:58. Go ahead.
I was going to say, I don't know if this helps people in like an example of what Liz just said, but I used to run gyms for a gym company out here on the West Coast. And we get so many people that would cancel their membership because exercise and eating a balanced diet is very difficult. I struggle with it all the time. I've struggled with my weight since I was a little kid, and it's hard, it's tough, and I hate it. And what I would see over the years is anytime new things would come up, people would run to that because exercise and eating well is difficult, but they'd always kind of have to come back to the gym and eating well. It doesn't mean that certain things that have come out, like about lower sugar or lower salt or whatever, isn't helpful to incorporate in exercise and eating well. But at the end of the day, that's what it is. And so every single person I've ever met, when I talk to them who is in recovery for OCD, they always talk about ERP. Now, I know some clinicians and some people don't like to hear that because they are very fascinated and interested in other modalities. And once again, Liz and I are not anti that. We just want to make sure that everybody that we come across knows that when making a decision of what kind of treatment to pursue, the research is very clear that ERP should be the front stop and the front line. So if you're not getting ERP, if that's not the frontline treatment you're getting, you do want to ask your clinician about that. It doesn't mean that what they're doing is not effective if they're using a treatment that shows some evidence backing that it's helpful intervention for OCD, but ERP has been shown to be the most helpful, and I want you to keep that in mind.
That's right. Yeah, it really is. And again, as more comes out and we have understanding of different modalities, we'll be the first to share it, and we'll be the first to talk about it and presenting on those. And we do present on them in different ways, but we're not going to present and label something different than what we know it to be. So to date, EMDR is certainly not an evidence-based treatment for OCD, but it is for trauma. So that's what's important to know. Is it doesn't mean it's not evidence-based for anything. It is so good to see y'all. We love being here and are just so honored and excited to have this space and time together. I cannot wait for our next live stream, which will be next week. Where we're going to have a special guest on, and where we will be talking even more about OCD treatment, ACT, and you name it. So Chris, I'll let you end it from here, but it's so good to see you guys, and I'll see you next week.
Yes, as always, towards the end of the live, you see me feverishly copying questions we didn't get to. So there was a good question about misdiagnosis. So I definitely saw that, Valerie R. We'll get to that next week. But yeah, thanks for hanging out with Liz and I. I really appreciate you engaging with us. You gave us so many questions, which gives us a lot to talk about. And we hope you took something from this live stream. But Liz and I are always extremely thankful for you coming out and hanging with us each Wednesday at 9 my time, 11 her time, 12 Brennan's time. But take care, and we hope to see you soon at a live, and keep fighting the good fight. We're here to support you.